I want to begin the next session with a question. Think of the most successful health intervention that you know of, the most innovative public health program, the most effective crisis response. Now take away the people, the doctors, the nurses, the community health workers, the program officers, the epidemiologists, the policymakers. What is left? I think, a rhetorical question that we don't need to answer. Health systems are at their core human systems, and the resilience of those systems is inseparable from the competencies, adaptability, and continuous learning of the workforce that animates them. Human resources for health systems resilience, HRH for HSR. The acronym may be a mouthful, but it asks a deceptively simple question. Is our health workforce equipped to build and sustain resilient health systems? Moderating this session is a public health specialist with over 25 years in health systems and services research, an advisor at Access Health International, a researcher, and an academician who has spent his career at the interface of health education and health policy. Please join me in welcoming Professor Bhuputra Panda. Next, I would like to welcome Dr. Priyanka Shrestha, a public health professional at the WHO CRO office who focuses on health emergency preparedness, antimicrobial resistance, and human resources for health. She works across the 11 member states of the Southeast Asia region to build the workforce capacity that emergency readiness demands. Please welcome Dr. Priyanka Shrestha. I now request you to join me in welcoming Dr. Vanicha Chungong from Thailand, an ophthalmologist and vice president at the, let me take this slowly, Prabhu Roma Raj Chanak Institute, which governs health professional education for one of Asia's most admired health systems. Dr. Vanicha is a leader in health workforce education reform, both nationally in Thailand and at various global forums. She brings comparative experience that is directly relevant to many countries' own reform agenda. A warm welcome to you, Dr. Vanicha, and thank you for traveling overseas to be with us today. Our next speaker is Dr. Neha Dahiya. She's a public health specialist and scientist D at the Indian Council of Medical Research with over 14 years of experience across clinical practice and implementation research. Her work focuses on mental health and non-communicable diseases. She brings deep expertise in translating research into policy and strengthening evidence-based public health interventions in India. A warm welcome to you, Dr. Neha. And once again, joining our panel is our CEO, Dr. Krishna Reddy, because the question of workforce resilience is inseparable from the dimensions of health systems work. Over to you.
Good morning. Am I audible? Good morning to one and all here. Very esteemed panelists and people from academia, representatives from research organizations, academic institutions, policy-making bodies, Government of India representatives, and representatives from overseas. Some of the public health scholars, researchers, and health system enthusiasts. So a very good, warm welcome and very good morning to all of you. This is actually an interesting opportunity for all of us to discuss on a very important public health topic, which is human resources for health. Stuti madam has actually set the context right already. She has made my job much easier by explaining the relevance and importance of this topic. And in the morning also, the session prior to this, governance for health system transformation, especially digital health transformation. Discourses were centered around provisioning and delivery of healthcare services and the importance of different building blocks in it. I feel of the six building blocks that have been officially recognized as the building blocks of the health system, the most complex of those is the one which is being discussed right now, human resources for health. The inherent complexity of this particular pillar lies in the very fact that we are dealing with complex people, I mean, complex creations called human beings. In a way, they differ from the rest of the building blocks in the sense all other building blocks do not have any emotions. This is the only one building block which is dealing with emotions. And of course, we know that when we talk about individual attributes, ranging from motivation, job satisfaction, commitment, competencies, to the spectrum that spread across the entire, you can say, continuum, starting from societal contribution or societal dimension to organizational dimension to regulatory dimension. Human resources for health has always been a very important topic of discussion across the policy arena. And until recently, it was being considered as something which is exclusively under the jurisdiction of the government of the day. But especially in the last one decade, where the contribution of the private sector to the provisioning and delivery of the healthcare services has increased significantly, and the establishment of private institutions in the business of offering education to healthcare professionals has also become almost jumped about 100% as compared to 2014. I'm talking about medical colleges, nursing colleges, dental colleges, and Ayush institutions, and so on and so forth. This has given a very new impetus to the discourses today. It is no more just considered to be under the umbrella of the government of the day, but it is also going much beyond that in terms of the role of the private sector. So, therefore, discussing human resources for health has to have panelists who draw from different experts of expertise of life, and we have actually four of the panelists who are going to take us through some of those important dimensions of this discussion. We have Dr. Uh, Vanicha, who represents a global alliance, international alliance. Dr. Reddy, an epitome of clinical care and also a clinician turned public health expert. Dr. Priyanka, talking about the representation of the WHO's perspectives on human resources and health, and Dr. Neha representing the ICMR, Government of India Research Organization. So I can probably give you a little more, 1 or 2 more minutes of discussions, and then we go to the panel. We have about 100,000 medical seats in the country today. I'm talking about India, of course. And this discussion has to go beyond the frontiers of India. But in this country, we have about 100,000 medical seats, out of which about 55% are in the government sector and 45% are from the private sector. Roughly about 50,000 of Ayush seats, about 27 to 28,000 of dental seats, and probably about 50,000 plus other professional seats, professional health professional seats in the country. Other than the requirement for getting into these institutions through a competitive examination, do we have any other mechanism for ensuring the continued assessment of their competencies throughout their professional journey, even after passing out? This is a larger question which need to be answered. And I think broadly the answer is no. And this is not just the case for India, but also many part of this country, this part of the world, what is called the developing economies of the world, which are grappling with so many other problems related to the health systems. Therefore, somehow or other, there has not been a consensus on establishing a national competency framework for not only gauging their professional journey altogether, right from the pass out of the institution till the end of their professional career, but also having a competency framework at the national and the subnational level. And the reasons are multiple. Some of them may be political, some of them may be agenda setting related deficiencies, some of those could be related to lack of consensus, and so on and so forth. But what is more important in all this deficiencies or in identifying all these deficiencies is the quality of care. So if health systems exist for the existential function of the health system is provisioning and delivery of the healthcare services, and if quality becomes the center stage of that provisioning, human resources and health has to be the engine of that movement. Because at the end of the day, as Dr. Reddy and other panelists also spoke in the last session, the primary stakeholder in all these discussions during these conferences, conclaves is only one, that is the patient. And therefore, any discussion about the career development, career pathway, progression, job satisfaction, retention, recruitment, distribution, competencies, any discussion on all of these facets has to have the center of it related to the patient. So with this prelude, I will actually want or I would request the panelists to talk on the different facets, the four important facets of this human resources and health for the day to day. And of course, this is not the entire list of the discussion that has to have, but because of paucity of time and also because of prioritizing some of these emerging issues in human resource and health, we've identified these four topics as relevant for today's conclave discussion. One is, I think, how do we go the order of the discussion? Is it open or do we have an identified order? But one is, one of the panelists, Dr. Vanicha, is going to talk us through about the role of the civil society and alliances for the human resources and health. Dr. Reddy is going to talk about the how and what is the need for shifting the gear of the healthcare education system in our country. Dr. Priyanka will be talking about the need for offering a policy development for holistic healthcare services. And Dr. Neha will talk us about the reforms related for developing the performance of human resources and preparing them fit for purpose. So with this brief prelude to the discussions, we will now request Dr. Vanicha. Should he invite? Yeah, so maybe Dr. Vanicha, if you would like to come and then take us through the first topic for the discussion. After I think there are three presentations. Dr. Reddy is going to talk extempore, and then after we can have few question answers for the session today. Thank you.
Thank you so much. You have some presentation?
Slides. Would you want to? Yeah, is there? No problem. Dr. Vanicha.
Thank you for inviting me to be here. I'm representative of different age conference. Who knows about the triple age conference? Who don't know about the conference? No one know, no one don't know. Triple age conference. Triple age is oh, okay, good. So you know already. I just okay. Just waiting for my presentation. I think I received the question on do we need a national competency framework and reforms on CPD, continuous professional development.
Yes.
Okay,
Next
next
slide.
please. Okay, I have no, just back one slide, please. I just to declare that I hereby declare that I am biased and have COI. I am biased towards all efforts to reduce health inequities. Please next. Yeah. So the two questions that I received from the conference, the host of the conference. Next, please. Three topics that I would like to touch. The first one, World Health Organization global competency towards USC. Second, current health care. The third one, how the system can prepare and lesson learned. Next, please. This is the World Health Organization global. Oh, thank you so much. World Health Organization global competency towards universal health coverage. I think Priyanka, you know about this. This is before pandemics. So this is the joint working among 6 regions from World Health Organization. For global competency toward universal health coverage, we can see the first one on the blue color, people-centeredness. So you know about people-centeredness very well. And the second one is decision-making. The third one is competency. And the fourth one, collaboration, and also the public and also personnel conduct. This is some information. Challenge to change. What is I heard from previous session on AI, on digital technology for health. And this one is the global digital transformation. The first one, telemedicine and remote monitoring. Since COVID-19, you can perceive very well. We cannot touch each other, so we can connect remotely. So telemedicine and remote monitoring are really important at that time. And right now, I think we still taking part on telemedicine. The second one is the digital revolution is very essential in healthcare and provide new options to healthcare professions in terms of disease prevention, diagnosis, and management. Augmented reality for diagnosis and health education, remote monitoring with portable connected medical devices. We have many medical devices for diagnosis and for treat the patient outside of the hospital in the community setting as well. And also genomics analysis to customize treatments and health sensor to enable patients to monitor their health. And also right now, it's very common, just recently, AI-based learning and platform and medical devices are developed for caregivers and patients with better health outcomes. I don't know, in this room, who work with caregivers, please raise your hand. Work with the caregivers. Okay, thank you so much. Okay, thank you. So you may share your opinion, your perspective on this issue later on. And challenge to change apart from those education or health service system, a home-based screening for GI disease and using pacemaker for remotely for detect for monitor the implant device and to do the EKG, for example. A cultural shift that has been characterized as the democratization. This is for everyone to access for health and also health security to focus on prevention and control of disease rather than treatment. Health literacy right now is changing for personal lifestyle, living condition, encourage the knowledge for personal skills as well. So how the system can prepare and let's learn so far. Right now, I think you recognize that the primary healthcare system covers even household, focusing on self, family, neighborhood, and community care. So primary healthcare is very important right now. Leveraging the point is that on primary healthcare system, it's easy to access equity and quality service at primary healthcare system. And this can induce universal health coverage. And this is may produce the better healthcare system at all levels. So we can say that good health at low cost. This is I show the healthcare system one I think in Thailand, but in some countries in Southeast Asia. Pirinya can share this later on. Right now at the center you can see self-care for individual and also family care, and also for population care we have three levels. So population care, they can take care themselves. In Thailand, we have health center in community. The one health personnel can take care 1,000 people. And also we have drugstore even private or public, and Thai traditional medicine center. This is very important in our country as well, and also private clinic. And at the second level, they will be referred the patients to the community hospital and also to general and regional hospital. The community hospital will become academic institute right now. Our student, our health professional student right now, they learn at the community setting. I don't think most of them, but a majority of them learn at the community setting, and to provide services and conduct research in the community hospital as well, because this is the best. It is the best based on the primary health care. In Thailand right now, I think is start with 900 community hospitals. This can connect each other and create network for powerful academic institute to develop Thailand's well-being. So this is the very, very important right now for academic issue for healthcare system in Thailand. You can see this World Health Organization report for health profession in the world. For our region, you can take note that in our region, the most common health workers are community health workers, which is different from other parts of country. And I conclude that for new competency for health workforce, right now we have very important 6 skills. The first one is to be a good coach, not only to teach but to be a good coach, and also to make a regular to make a good communication, and also for technology, and also the fourth one is empathy and supportive mind. This is very important right now. We integrate this in our curriculum for health professional education, and critical thinking, and also professional insight into for other. So I would move to the second part. Do we need the continuous professional development? I can say that CPD is easier for me, and it may shorten my time to talk about this. For CPD, you can see this is, this is the COPS learning cycle. I think in this room, this cycle very well. It starts from the conceptualization, is very abstract. But when they learn and reflect, you can get the active experimentation, and also concrete more and more. And this reflective observation can reflect those capability, professional capability. And in addition, Kirkpatrick's model for evaluation. This is, I think, this is the best, the best evaluation concept. The first one, reaction. Reaction is to measure the learners that they react to the training. Are they satisfied? Are they engaged? Or are they relevant to their knowledge that they get or receive from their coaches? The second step is learning, to assess the increase in knowledge, skill, and attitude, and also behavior. The third step, to evaluate the extent of which learner apply back to the job. And the fourth one, the top of this evaluation is the result, to analyze whether the learning outcome that they get, this is can be benefit to the community, can be beneficial to the community or not. So I would like to conclude my talk for the first part, is for competency. Right now, we should shift from time-based 2-year, third-year program to outcome-based training. They may complete their program before their 3-year program or 2-year program. So this is for their learning their knowledge, for their learning the knowledge, and they can apply for their for their after they successful, after they success the knowledge. Second one, the interprofessional and simulation-based and IT-based education for population health. The interprofessional education right now is very important in the world. So not only learn together, but also practice together as well after they complete their learning. And practice-based learning and assessment tools and adaptability to crisis. Right now, we have many crises, not only emerging disease, but right now even handmade battle or natural crises. For example, flooding. The fourth one is ensure fair employment and job security after they finish their education program. Preparing our workforce to respond effectively to emergencies, crises, and addressing the challenge posed by aging society. I think every country now approaching the aging society already. And also for CPD, we should align education with accreditation system in the real world demands. For medical professional education, for example, World Federal Medical Education is international regulatory. And to reduce silo via interpersonal approaches and support CPD addressing health workforce shortage and enhance resilience through research capacity monitoring and equity focusing training. So this is very important. I would like to close my talk with this. You can see this, Donald Duck very well is to turn the face upside down. What happened? Thank you so much.
Thank you. Thank you, Dr. Vanicha, for such insightful thoughts, especially the last few slides. I think you have hit it on the head. You have given the context. Now open for the next speaker to talk on the reforms that is required in the health education spectrum. I will request Dr. Reddy to kind of give us a perspective as a clinician turned public health enthusiast, public health leader, his perspectives on this issue. So, sir, Dr. Reddy, over to you.
Yeah, thanks, Bhuputra. I think since not only as a clinician but also responsible for building healthcare delivery systems,
Yes,
and grooming people to deliver people-centered healthcare, some of the reflections are from these practical thinking where the current education system is fit for purpose. What actually the current health needs of people demands. I think that's where my thought process comes into what reforms are required in not only I look at two stages of health professional education. One is education to certify you as a doctor or a nurse or allied health professional or community health worker or caretaker, whatever the title, where there is a defined knowledge is defined, what knowledge is essential for you to be a doctor, what you to be a nurse, what skills are essential to be a doctor or a nurse, and more importantly, what is not taught, but what is much more critical as a professional, as a medical professional, having taken this professional, are you taught the required value systems of a doctor, of a nurse, who takes care of another human being? I think so. That is, I think, one dimension in a formative stage of the health professionals at an education stage is required. The second is, unlike when Flexner designed this health education system, medical education system, it was focused on hospital-based curative care. And 100 years have passed from the Flexner's report on which entire medical education evolved globally. And we continue to train our students in the same education system that evolved 100 years back at that context, where it was a hospital-based curative care. But since then, we have evolved to understand the importance that it is not just curative care, it is from promotive to palliative care. That means entire life cycle of a healthcare need. So how are these students trained in this life journey of a patient from womb to tomb, from promotion to palliation? They are continue to be trained in the hospitals, the nurses and the doctors. A ideal student today should be trained in what is an ideal healthcare delivery system, which is patient-centric or people-centric. I would say people-centric because now health promotion is part of a health professional responsibility and competency. When we say health promotion, we are talking of health promotion to healthy people and patients. So that's why we should not call patient-centered healthcare. It should be people-centered healthcare. So that is one. Secondly, in a model delivery system today, has to be an integrated delivery system starting from home to the highest level of specialized hospital. So that means it has to be an integrated system where the patient's care is looked at on a continuity basis, whether they present to a hospital, whether they present to a primary health care center, whether they present to a community health volunteer. Ultimately, the journey has to continue in a seamless fashion. So that means any student, if they have to be really ideal in a people-centered healthcare delivery, has to be trained not in the hospitals. It has to be in integrated healthcare systems. That means, in fact, once they complete their fundamental foundational knowledge and skills, their journey, training journey should start from the primary care or the community care. Then they should track the patient to the hospital and learn what is done in the hospital. Then they should follow the patient back to the community, that what happens when the patient gets discharged. Otherwise, as a doctors, we don't know what is happening after the discharge. Who is taking care of them? I mean, they are in the ICU, you shift to step down and they're discharged. You are monitoring every 6 hours, you are monitoring every 8 hours, then suddenly you discharge and say that you are on your own. What happened? I mean, you are so intensely monitoring, suddenly on discharge, they don't become unmonitorable or they don't require a monitoring system. So that is, I think, one component. The major component is in which healthcare system you are actually training our health professionals, whether it is a public health professional or whether it is a health management professional or a clinical professional. So I think that is one fundamental reform has to happen. Whatever the standards are there today for NMC or international lines, they have standards only for what should be the principal room, what should be the doctor's room, what should be the bed size. That is not the standard of an ideal healthcare system where the student has to be trained. Yeah. Second, the competencies required in addition to the clinical competencies. Today, the competencies of a health professional are not just clinical competencies. They need to know the cost effectiveness. That means you need to have economic competencies. You need to manage a team of people. You are not an individual doctor. So that means you need to have a behavioral competencies or communicative competencies or social competencies. Or the technology is evolving, the disruptive digital technologies, disruptive molecular technologies. Are we tuned with this technological aspect of competencies? So we need to redefine what type of competencies are required in the current and the future state of health system and health technology. So that foresight is not there in today's education system. Okay. Then the second phase, when the education stops, a healthcare professional, the actual learning journey starts from there. It does not end with getting a degree. So unlike any other profession, the learning starts from there and it continues until I stop my profession. You need to learn daily. So what is the culture of learning the daily along your care? Are you spending some time, 1 hour a day, for learning, for discussing? I mean, because patient is our book anywhere. So that is the second component of reforms that, I mean, just like when you build a hospital, when you have an equipment, you maintain it, ensure that it does not break down. It starts functioning like what it was stated to be functioning. But healthcare professionals, don't they wear out? Who is mandating that they have to maintain their competencies and throughout, so that the patients are secure in their hands. The way the knowledge is expanding, an ignorant doctor is more dangerous to the patient than no doctor. Okay. So if you have that ignorance to be allowed, that means who is actually assuring the safety of the patient in the hands of the health professionals? So why we don't mandate that people have to be continuously updating their competencies so that they remain safe and effective to the patient care? So these two-dimensional reforms have to happen. I mean, in fact, as an organization, we are trying to actually bring these ideas into our own health professional education system. I mean, incidentally, Bhuputra is leading that institution where we are trying to implement these reforms, of course, within the legal framework, within the standard framework. But luckily, the national education policy permits a lot of flexibility and agility today to innovate in health professional education and also scientifically validate. Since I have my WHO professional and ICMR professionals, we need to, whatever this theoretical underpinning of reforms in health professional education has to be validated rigorously scientifically. That, as Vanica has mentioned, the ultimate impact of this reform has to be felt in the patient health and their health outcomes. That is the end point of testing whether this hypothesis that you need a reforms in the competencies has to be validated in scientific fashion. I mean, it should not be like an individual personal opinion that we then only we can convince a policymaker that this mode of teaching, this mode of competency maintenance lifelong is effective and impactful in terms of transforming the health of the people. So that has to be designed and demonstrate that how it is actually impacting the outcomes of a well competent professional and compare with the usual case professional. I mean, we can do a double-blind randomized study, not double-blind, but at least the randomized study, we can do that. Yeah, these are, I think, my preliminary thoughts on what type of reforms are needed, but whether they are feasible to implement it. As experimenters, we can do that, provided the regulators permit us to do that experimentation. But I'm very keen to actually experiment on these reforms at an institutional level, and then maybe go to the policymakers that, yes, we have done it, we have demonstrated that it is working. Then you can convince the policy advocacy. Yeah, these are my few comments.
Thank you, sir. I think very important observations. And I agree that unlike the other building blocks of the health system, which are more or less objectively verifiable and measurable, the HRH and the governance, these are the two pillars where you have you have a lot of inherent difficulties in identifying indicators to measure the performance of these two pillars. You can have proxy indicators, but unlike technology or health financing, where you have direct indicators to monitor, HRH has many such inherent difficulties in measuring the performance. And of course, relating it with the patient outcomes, quality of care, quality of life index, and some of those outcome and impact level indicators, those need to be actually studied in greater detail. And I think yesterday also, Dr. Sangamitra also mentioned in the inaugural session itself, the need for kind of going ahead with the idea of kind of experimenting with the health education platforms of the country today. So I think we will, these are some of the cues to action. I hope some of us are taking note of it as a part of our take-home message and work further on those. Having said this, we will move on to the next panelist, Dr. Neha Dahiya from ICMR. The topic she is going to talk us about is how can health workforce continue to perform and find purpose to their work? Would you like to?
I have a
Presentation? Yeah, sure. So, can I request? Yeah, it's there.
So thank you for the opportunity, sir. And I completely agree with my previous speakers that this human resource is the most important component of the health system, and it is the most difficult as it requires a behavior change, which is a very different and difficult domain. to change a behavior, but still we have strategies, and if we continue on that, maybe we'll achieve this. So I'll be talking about the reforms that can be done for the continued professional education. So, as I told, that there is a mismatch with the evolving needs, and there is a mismatch in the demand and supply as well. So, our current and the traditional continuing professional education system, it is a very episodic thing, theory-based, compliance-driven, that you need to complete this task, and then you will be given a degree or a certificate. But it is not based on the real-world setting and the impact which is required. And there is and we don't focus on the outcomes, we just focus on the processes, that you need to do this, but we are not very aligned with like what should be the desirable outcome. So that also leads to, like, when we are trained in the medical, so I'm a medical doctor, so when we are trained in the medical system, we are trained in a certain way, and that you need to pass these exams and then you will be having a degree. But it is not necessary that you will be having that skill also.
Absolutely.
So, and in the COVID, we have realized that our public health system is also not very equipped with the skills that is required to cater to any public health emergency also. So, I'll skip this slide because we all know that CPE is basically a systematic ongoing process of learning. And this is mainly after a formal education, which aims to maintain a competency and improving the quality of care. So it includes formal trainings as well as the informal trainings. So the CP is a very important component because the technologies and the knowledge, they are evolving at a very high speed, and we are not very prepared to adopt these. So that's why we need the health system reforms. So what we need to do is we need to shift from the credit collection to a competency-based lifelong learning. So as we all know, we go to conferences, we collect credits, and then we are eligible for a certain fellowship and for few more things, but we don't focus on what we actually gain from that, whether it is going to help in the real world setting or not. So in other countries like UK and US, they have a system where that is based on a milestone-based competency framework, where professionals are assessed on the real-world skills, not on just on the degrees and completion of a certain task. So, so the message is, like, attendance is not competence. Our system must measure what clinician can do, not just what they attend. So, second is we need to learn while working. So, as we all know that there is a paucity of professionals in India. So, so doctors, they have a very long working hours, and then they face the problem of burnout. So, and there is a no separate like time for a specific training. So what we need to do is we need to embed that into a continuous thing, into like learning while working. And for this, like, I'll just give an example of ICMR. So we have developed a one clinical decision support system. As we know, there are CHOs in a public health system, and mental health is not considered as a priority in various developing countries. So, but now after COVID, we have realized that this is a very important field. So the problem is we don't have psychiatrists. So there is a CHO. We are trying to do the capacity building of the CHOs, and we realize that the main thing is that we have given them the theory-based trainings, and we have modules, but they don't know what actually they have to do. So these clinical decision support system, they empower them to like make a decision when a patient is there, and what exactly to do, and when to refer, how to refer, whom to refer is there. So, I'll say that the future of the education is not in the classroom, it is at the point of care. So, AI is there. So sometimes we think that AI will replace us and how the things will be in the future. So I think that AI will not replace doctors, but it will redefine how a doctor can take a decision and work every day if we like apply this very carefully. So sorry. So these days, there are systems like simulation-based platforms are there where the medical doctors, they have been trained in the emergency. So we need to do more of these type of things in the real world settings also. And also we need to move beyond the clinical skills to include the purpose in the work which we are doing. So we are doing work for just sake of doing that we have to do. We are a doctor, we need to see 100 patients a day and so on. But sometimes that lacks the joy of doing the work. So but still, the government is taking some steps to address these issues. So I'll just give an example of a Karam Yogi training. This is a very recent thing. So all the central government employees, they have been trained in this training that where the focus is on functional competencies, behavior competencies, and the domain competencies. Which can be applied in day-to-day life. And there are certain case scenarios, also case studies, like how we need to behave when a certain type of problem arises. So that's a very good example of this thing. And yes. Then also we need, so we are expecting a person to increase the knowledge and increase the degrees, but we need to do, but after getting a job, we don't have any motivation to do that. And we just do that for the, just going to the conference and getting the credit hours. But if it is linked to a career progression and incentives, I think that is going to a main factor for the motivation behind doing this, and finding a purpose in doing that. So in ICMR, we have a recent change, like for us who are the permanent employees. So I have an MD degree, but because I'm working in a research organization, so they are promoting a PhD degree as well. So we have a collaboration with ACSIR. So if you are a permanent employee, there are certain modules and you have to go through that, and you can do your PhD degree as well by doing the work also. So yeah. And we need to see the decentralization and democratize the access. So we know that there is inequity to the access of care also. So in the rural areas, we don't have the basic facilities also in terms of the patient care as well as the education. So we need to see like how we can develop some digital platforms where theoretical training can be given through that, and the hands-on can be given on the field. So we do have certain projects like Project Eco is there, and then IGOT is there, where the government is giving some trainings to the people to reduce the access to the inequality in the access to the quality CPE. And also, we need to have the regular trainings for the pandemic and disasters, because usually we have seen that we cannot train during a crisis. We must train for a crisis. So during COVID time, we realized that a lot of things have, like all the meetings, they shift from the physical mode to the online mode. And there are certain innovations also, like the government, they have done a Vishnu Yudh Abhyas, where a mock drill was performed in collaboration with the NCDCs, ICMR, and the other state government, where there was a mock drill on like a virus was given, and it was seen like how the people are doing the things and how they can be improved and what to do when the next epidemic or such crisis emerges. So yeah. And also, like I said earlier also, like we need to measure impact in terms of not just learning that we are learning. We need to see that this learning is translated into the patient outcomes as well. So it should be the CPE should be linked to the clinical indicators and the system indicators or the patient outcome indicators. not just the certificates. So yeah, so this is an example I was giving earlier also, the ICMR mind study, the CDSS. So I've already explained, so I'll not go into the details. So this is just an example of the capacity building of CHOs and the medical officers so that they can deliver the mental health services at the primary level as well. And similarly, for the doctors, we also have a ICMR, Indian Clinical Trial and Education Network. Is just an example. Like even after the see all the principal investigators, they are like well-trained researchers, but still everybody needs to upgrade themselves. So this is a hand-holding program where there are webinars and the hands-on trainings are given, like how to do the trials. So yeah, thank you.
Thank you. Thank you, Dr. Neha. I think she has given a interesting perspective about the role of ICMR in shaping the human resources for health portfolio of the country. Being a research organization at the national level, ICMR has a very important role to play in kind of giving answers to some of these questions, which we all are, as researchers, grappling with in terms of improving the performance of people working at different levels of the healthcare delivery system, improving motivation, job satisfaction, and some of the personal attributes, as Dr. Reddy highlighted, the competencies related to the social, the digital, and the interaction level competencies of the health professionals. I had a very interesting experience last week only in a tertiary care hospital in Bhubaneswar, where there was an issue of a conflict with the care provider, critical care provider, with another patient, the relative of the patient. The problem was mainly because the critical care provider probably I felt was not ready to have the counseling capabilities with the attendant, and that led to the conflict. So these are some of the kind of issues and problems which are giving us a lot of these questions to answer. And on the one hand, for example, in Odisha, for that matter, in many parts of the country, at the state level, you would find a vacancy of about 25 to 30% of health professionals. Most of them are doctors. And from the public health delivery point of view, because there is somewhere a gap between the urban and the rural divide. Hospital service provider, especially the physicians, are not very keen to work in the tribal and the urban areas, and there are regions very well obviously known to all of us. Nobody would like to work in those settings. Some of the answers related to those problems lie in the non-health determinants of healthcare provisioning. But individually, personal attributes like competencies, counseling abilities, commitment, and then compassion, very important value, which is not being taught in any formal medical or nursing or a dental education framework, but those are required for the country as a country to head towards that high quality health service delivery for the patient outcomes. So with these observations, I will now request the last but not the least most important topic to be discussed today is the deployment of the professionals for holistic healthcare services by Dr. Priyanka. So building the fit for purpose health workforce, she is going to give us a regional perspective being representing the WHO share region. Over to you, Dr. Priyanka.
Thank you. Good morning, everyone. As we gather here today to discuss very important topic, if we require national competencies and continuing professional education, it is very important to pause and reflect back to our history and how we are here. Okay. Fundamentally, back in 2006, the World Health Report highlighted that the greatest shortages in human resources for health was seen in WHO Southeast Asia region. And fast forward to today, we see we now produce the HRH at a scale comparable to 36 OECD countries. Take India, for example, it produces over more than 100,000 medical doctors every year, in addition to other health workforce. And the scale is enormous. And it continues to grow rapidly in today's changing world with multiple shifts of demography, epidemiology, climatic, geopolitical, humanitarian, technological, including when we are witnessing that population are becoming more informed and they are more empowered with the changing expectation from the health system. So today we have our question, how can health professional education keep up with this evolving context? So we'll listen to this conversation in our very recent workshop. Could you help play this video, please?
The numbers have increased in the Southeast Asia region, but are the numbers fit for purpose? Can they deliver on the promise of universal health coverage led UHC while getting ready for the other challenges that have already been recounted, whether it's aging, climate change, NCDs, and so on, pandemic threats? In terms of context, content, quality, and competencies, is our health workforce ready? And we have also been training people in numbers in silos, doctors, nurses, technicians, and primary healthcare workers. Have we trained them to function as teams? Is that something that is missing in our primary healthcare context as well as in clinical care context?
I will give you a very straightforward answer. It's damn unfit for purpose. Not just unfit, damn unfit. Look at our health professional education. We talk about a lot of a huge number, biggest in the world in this region. But where are they? Who take care of the rural people? Who take care of the urban poor? The brain is big, the heart is getting smaller. They are technology-driven, silo specialists, super specialists, less and less GP. More expensive, but less health. How can we call this fit to purpose? Never. And of course, it's context specific, but we never keep up with context. Our health professional education and health professional management never be able to keep up with context. We don't need a reform. We need a reborn of our totally change our idea. Move from Flexner report 120 years ago to more system-based, to more interprofessional team-based, to more primary care-based.
We have lost the element of compassion. When I read the history of medical education, I feel that maybe 100 years ago when the SLMC was being born, I think our doctors and the health workers probably displayed, from what I read, more compassion than now. They didn't have the gadgets that we work with now. Now we are much better technologically. We can diagnose.
Okay, maybe due to the technical glitch, maybe I can summarize. We'll go
to the level problems that we have. Now all that is good, and I'm sure
Yeah. We'll move to the second one, maybe. Yeah. So basically here, we see that there's a very strong recognition across the region that we need a focused attention of quality of our human health for resource. And it is also a major quality concern where 60% of death are due to poor quality of care. And rest of them of non-utilization of healthcare system. So beyond strengthening of clinical skill and quality, we have during our range of regional discussion over time, we have highlighted these 5 area of priorities. So first one, health humanities. How do we define it? So health, medical or health humanities repositions health within this broader context of social, cultural, and historical context, and the tools we use to critique the complex environment around the social illness and health. So we have this image from this Georgetown Medical Center Medical Humanities Initiative, a picture of Asian origin that reminds us that medical knowledge is not fixed, rather shaped by history and culture. And different society understand human body as a different in their own ways and offering a very meaningful purpose. So this was also very relevant with our very recent visit to Chhattisgarh, a district, Dantewada, where a district hospital is going to be established as a medical school. And the local context of more than approximately 70 to 80% of the tribal population there, the local context and cultural understanding are becoming very important. And from my own experience back in Nepal, we had this opportunity to have 2 weeks of health humanities session every week during our basic sciences period, first to foundational period, where us for students, it was a very eye-opening experience where we came from a very urban, easy background. It was very important for us to understand the diverse context, social context, how it changed or shaped a patient experience, and how care delivery should be very thoughtfully aligned with those realities within the health systems. In 2022, Sri Lanka proposed a resolution of introduction of health humanities, which led to a rapid regional review, which identified several forms of health humanities in pre-service and in-service training, and saw opportunity to advance this more systematically with our rich cultural background and strong capacities within the region. And we can also see with examples across our region where quality of care is poor, that 70% of the patients reported doctors appear to be hurry. That is, the interaction between the patient and the provider seem to be issue. And in India, a systematic review showed 70% of patients found some kind were experienced some kind of disrespect and abuse during the maternity care. So fast forward to October 2025, first of its kind resolution was adopted in our 78th Southeast Asia Regional Committee meeting. And now this is not only a concept, but it is getting in place in Sri Lanka. In very recently, 17th March, a national consultative meeting on implementation of WHO resolution on health humanities brought together medical deans to discuss how to advance this agenda forward. And a very powerful step following this was an official letter from Honorable Health Minister from Sri Lanka to the Prime Minister, who also have the portfolio of Minister of Education, mentioning the importance of embedding health humanities into the education curriculum. Second, social prescription, very new term, but a very old concept where healthcare approach, where healthcare workers prescribe non-clinical interventions, which could be community-based to improve health and well-being. It could be exercise, it could be healthy food, and also addressing underlying social and practical issues we have. And there is growing global momentum around it, with this approach being implemented very globally and in country. There is Food in Medicine program, which integrates food-based nutrition program within the health system. And we also have CMC Vellore, which is giving PG diploma in lifestyle medicine. We also have upcoming policy brief incentivizing equitable access to healthier food through health system through WHO headquarter. WHO Academy is have social prescribing course online, and WHO Wipro along with Lancet in Jan 2026 launched a series of social prescribing in Western Pacific. And a very recent Lancet study also showed UK alone, since 2019, 5.5 million of GP included social prescriptions, and along with 1.3 million alone in 2023. Now, this topic has also emerged in our very recent PHC forum that happened in Kathmandu. In our region, a country like Thailand is already institutionalizing the social prescription within the system, with village health workers being a link worker between clinical and community. Also, they also call for a regional social prescribing framework as they move forward. Similar approaches can be seen in Singapore, where they are training healthcare workers for health and social care integration within the system through competency-based training program, and building continuity of practice in social prescribing. It also identifies personal traits around what kind of health workforce do we need. And they also identify competencies like masterful communication, active listening, empowerment, community engagement, navigation, and coaching, which already have been discussed by our previous speakers also. Next, we have prioritization of team. Now, as we have moved far forward from the area of very isolated and autonomous practice we used to have, and as Professor Harry Caton in the picture we can see, emphasizes that traditional professionalism, which had very traditional pillar of mastery, sympathy, and autonomy, are now evolving into a new professionalism, which is more centered around relationship, where we need expertise instead of mastery, empathy instead of sympathy, and mutuality instead of autonomy, which reflects our shift towards shared decision-making, collaborative practice, basically a teamwork. So we are already seeing these kinds of model in Meghalaya, India, which is actively being prioritized. And Thailand also brought together 150 participants across a range of healthcare workers very recently in November 2025 to advance multidisciplinary team leadership and collaboration. Okay, strengthening public health competency. I think COVID-19, we all know, have shown critical gaps in our health workforce, and these have become very evident. So therefore, we have very increasing focus on strengthening public health capabilities alongside the clinical skills we have. Already mentioned before, this is the global competency outcome framework for essential public health function, which is informed by 126 existing competency framework. It identifies 20 interrelated competencies and organized around 6 domains, as mentioned earlier, like a community-centeredness, collaboration, communication, shared decision-making, evidence-informed practice, and personal conduct. So there is, as we speak now, there is also ongoing work in Geneva. They are developing a national workforce capacity for delivering essential public health functions, with countries like Thailand, Maldives, and Timor-Leste already engaged into the process. And with that work would be complementing a regional workshop on essential public health function, which will also give opportunity to advance a regional public health network, which is a voice around our region, which aligns with broader regional priorities like AAAH and Access Health Global Learning Collaborative Platform we have for resilient health workforce. And at last, as we stand at the cusp of healthcare evolution, as our previous session we had, now we through the revolution since industrial revolution, we had from public health response to very specialized care and very large institution we have in places to digital and information driven system. And now healthcare 4.0 brings AI and continuous learning into play. So digital competence is no longer optional, but very essential, which will also be reflected in our upcoming global digital health competency framework, which will be for policymakers, planners, and practitioners. So as we advance health 4.0 with new brain and new hands we have, I think we should not forget the heart, where we have been discussing where are people within our system. So with this, advancing this progress must not come at a cost of compassion and humanistic care. Thank you.
Thank you, Dr. Priyanka. She has given a very interesting perspective. In fact, as a professor of public health, I asked my students, how many of you are interested to go and serve in the rural areas? And as a student of health governance, I also asked the same question. How do we improve the skills and motivation and job satisfaction of people at different settings of the health of the work culture? Governments are also grappling with the same issues on HRH. The answers are not as simple as are being discussed or thought to be, but I think probably somewhere the answer lies probably way before the medical education, the child rearing practices, and some of those are also related to the individual traits, attributes, and then getting into medicine cannot be a symbol of status. It has to be much more than status symbol, and therefore regulatory frameworks must also have to be aligned with the national priorities in terms of aligning, in terms of engaging and deploying human resources for health. If you are interested for establishing a very strong and robust framework for obtaining the accomplishment of Millennium Development Goals and some of the national goals that we have set forth in different parts of our life. So with this, I will now actually request, unless there are other specific points to discuss, I'll request the audience to throw questions to our panelists. So there are four diverse set of perspectives given on HRH. And as I had mentioned to you, this is not the whole HRH in its entirety, but we have identified some of those important priorities for this year's theme. And therefore, it's open to all of you audience to kind of, ask. Yes, I think there is already one. Yeah. Second.
Thank you. Thank you for the presentations. I'm Srinivas Reddy Marugu. I practice in the United States, and I'm a student of Dr. Krishna Reddy. I trained in Usmania and Hyderabad in the 90s and then moved to the US right then. And I've been in the US for 30 years now. So I've been an educator. I'm mostly in the graduate medical education, so the residency side of training more so than down on the undergrad medical school training. To me, it's fascinating after 30 years in the US and watching the evolution of this conversation. And I came here, this is my first time coming to this conclave, is I was expecting to hear problems and maybe discussions that were significantly different than in the US. What strikes me the most is that what you're discussing here is almost identical to what's being discussed in the United States.
Okay.
I was in the Netherlands last year looking at their health system, which is structured much differently than the United States and much differently than India. And they are struggling with essentially the same issues that you are struggling with. So at least one takeaway for me is that the struggle is a shared struggle. And therefore, I would hope that lessons can be broadly learned across continents, across socioeconomic statuses within countries. So there is hope in that, because this means that this is a shared problem all of humanity, really, no matter where we live, is having. I have a couple of questions and maybe some more comments to make. One of the questions I have is, Dr. Krishna Reddy, you made the comment even yesterday when the discussion was around quality improvement to say, where are the managers of quality, the quality managers. How are they being trained? How do they work in this team? Today and yesterday, I think we talked about value, moving from volume to value. We talked a lot about insurance and insurance structures. We talked a little bit about quality in the sense of how do insurance companies incorporate outcomes-based payments as well. So the related question for me that brings both of these is, as we talk about interprofessional education, which appears over and over again in these conversations, is we must train. I'm not quite sure I'm hearing that tent of interprofessional includes quality professionals, insurance professionals, the people within the hospital who are interacting with the insurance professionals. They're on your team, you're on the provider side, but you're employing people who work with the insurance company. Where do you see them sitting in the education process today? Where does the quality expert sit in the medical students' education, or even in the already in practice and a lifelong learning physician's environment? Where does the insurance professional fit into their life?
Yeah, thanks, Srinivas. In fact, that is the biggest gap that we find today. I could not cover all the competencies that are required of a modern medical professional, is the management competencies. I mean, incidentally, the management science emerged from medical science and the military science. But now the medical science and the medical professionals are managed by management professionals. Whereas an ideal setting is where the medical professionals, when they evolve in their career and they're required to manage a department, required to manage a team of people, or required to manage a facility or a system, why they cannot have the management competencies along with medical competency? Because they are essential. They are part and parcel of their medical profession. So that is one. I think the management competencies should be part and parcel of medical. Like I devote myself 50% as a clinician and 50% as a manager. Of course, I am self-styled manager, so I developed competencies because I was interested in that, or I was required to learn the competencies because I was managing a facility. So instead of that, in fact, we encourage actually our nurses and the doctors to acquire as a part of the daily learning session, not even as a separate degree or thing. Even after their graduation, we should, as they evolve from the junior cadre to the mid-level cadre, they should be introduced to these competencies in management. The second thing, which you again brought out in terms of our medical practices, are influenced by what the patient is eligible under the package. So our guidelines go haywire when you know that this treatment is not covered, this treatment is covered. But we are not trained in that direction to understand the health economics, the health insurance concepts, for us to adopt to the actual prevailing situation of practicing in the context of strategic purchasing. That means if they are demanding something, so I fully agree with you that these competencies, I mean, that is exactly what we say fit for purpose. I mean, fit for purpose competencies, these are the things. I think the whole objective of this type of dialogue is to bring out what is the list of competencies at what stage of professional career. Because if you want to load a medical undergraduate with all these competencies, they may not be useful. So we, as we all agree that there has to be continuous professional education and continuous competency development. That means we have to position some of these competencies in the course of the professionals as they mature to a managerial level or a leadership level. As a leader also, they need to have the leadership competencies. So I fully agree with the points that were raised, and I also fully agree that the problems are not just India specific or Southeast Asia specific or Asia specific. They are universal. Maybe subtle differences are there, but they're universal. I fully agree with that. Yeah.
Thank you.
Thank you. Thank you so much. Dr. Manjunath, is your question. I'll come to you, ma'am. Second.
Yeah. Dr. Manjunath here from CACP. My question is mainly concerned with Indian and medical education, but it may be applicable to others also. Like I was having a conversation with Professor Anurag Bhargav like 2 months ago. He is a professor in Kasturba Medical College, one of the top colleges in medicine in India. And he was saying that even in first year, second year MBBS students, they're preparing for NEET PG. They are no longer worried about this. And if you see the whole, when I was learning my 11th and 12th standard, we used to go to the 12th standard, but going to tuition or other was optional. Like we would go in the evening. But now everyone is going to Akash or Island or something, and going to 11th and 10th school is optional. So there is a overwhelming this thing about the education is only purpose built to pass the exam, the MCQs, how do we answer the MCQs, etc. And in that way, the core, the whatever the compassion, the core competencies, etc., those will get a back seat. So how do we solve that problem? There is no incentive for students to learn those competencies. They are all focused on cracking the exam. So
That the question, you have any specific speaker to the question is
anyone can answer,
I
but
think-
I don't know about the other Southeast Asian countries. But India, I know, like I've observed it.
So I'll again request Reddy sir, because he himself has been at the top of the healthcare service provisions and has learned a lot from last 30, 40 years of his clinical practice. So
No, the point is exactly, because as a medical student or any clinical professional, or any, for that matter, any professional, is looking at what is the market after they pass out.
Yeah.
So as a medical professional today, the patients go that if they have headache, they go to neurologist. They have a chest pain of spondylosis, they go to cardiologist. They have cough, they go to pulmonologist. So naturally, the student is worried, even at undergraduate level, will I survive with a medical degree?
Yeah.
Right. So naturally, and also imagine the competition. If one PG seat, there are 20 people or 30 people or 40 people competing. So it is a basic human survival instinct as to where to invest their time and energy and effort, right? So that is where the policymakers have to look into. Is our incentive system of super specialization is a wrong incentive system? So the payers, healthcare payers, have to look into, are we incentivizing super specialization? Are we incentivizing what is the most demanding service of a clinical professional is a correct diagnosis.
Yes.
But you are paid only 300 rupees or 100 rupees for that. And most easiest to do angioplasty, but you are paid 20,000 for that. Both take same time. So the incentives actually tilt how the students or how the clinical practitioners actually change themselves, adopt to that practice. So it is not their mistake. And in fact, some of the private educational institutions, now they're collecting donation upfront to pass them.
Yeah.
So that they can prepare for NEET, PG. So we have to look at from a systems perspective, and if policymakers are able to visualize this system perspective, and where the change, where are the levers to bring this change? Systems are too complex, so they need to be identified, or even the researchers sitting here need to identify in a complex social systems. How do you identify that critical lever which can create the transformation? It is not a simple mechanistic model that you push like a bus, right? It's a complex social system. So that's, I think, students of health systems will understand how to apply those complex simulation of complex systems thinking. Suppose I want to take a decision that I will pay for consultation the highest and leads to a procedure, right? Then you can put into the simulation model of complex systems behavior and predict what is going to be the unintended or intended consequences of that. Yeah, there is a science actually to address the simple question that you asked, but do we have those researchers to do that? So, I mean, that's where I think yesterday, I think Sangamitra was mentioning, we need to research health
Yeah.
professional education itself.
Absolutely.
I think that is a interesting idea that came yesterday.
Yeah.
So I was impressed by that idea. Nobody researched that much as on the other side aspect of health.
In fact, at the very introduction of my talk today, also I mentioned about how complex this HRH is. It's not just only an individualized phenomenon, but it's a systemic issue. It's an issue which need to be considered at different layers of the healthcare delivery system, right from individual attributes to regulatory to societal and organizational. So some of those which you are pointing out is actually related to societal. The way we have been brought up by the families, the way we look at our career, the way we look at it, earning money, and those some of those components. Very complex, but then need to be kind of studied in its in bits and pieces. Madam.
So very rightly said. I think we need changes both at the education system as well as our service delivery system also. So when we are doing our graduation, we are doing our MBBS, we know that even after doing the MBBS, and if you go for a private practice, nobody is going to come to you. You need to have some specialization, or these days, super specialization. So we don't focus on the skill. We focus that, yeah, we need to clear these exams and the entrance exam, and then we have to do the specialization. So I think at the system level, we need to make certain changes. At the delivery system level, also we need to make changes. So everybody comes to the tertiary care directly without going through the primary care. So if we make certain referral pathways, which are very strict, like in UK, you cannot go directly to the specialist doctor. You need to go to the primary, and after the referral only you will get the appointment. So I think it will change the system, so people will be prepared. Like, people are going to come to us. Even if we'll do just MBBS degree, everybody has to come to us first, and then based on the complexity we need to refer them. So yeah, it's a very complex.
Yeah, thank you.
So all the stakeholders, they need to sit together
Absolutely,
and
absolutely.
have a co-development exercise, and strategies are
co-design and co-development.
Yeah.
Absolutely. So we have shortage of time. I think probably you can entertain one more last question, Madam Malaram.
Thank you. It's a few observations,
Yes.
as well as a question. In Britain, as you rightly pointed out, ma'am, the primary care, the GPs are, I suppose about 4 decades ago, it began, this whole thing of trying to ensure that the system recognizes how important they are and what a critical difference they make to the system in terms of both, cost effectiveness and efficiency. And as a consequence, GPs are referred to as generalist specialists. So, they too specialize in being generalists. And that, there is an understanding among the professionals that it is as tough to take the risks when you see a patient with fever, to know that it's going to be something that will resolve in 24 hours, or it's going to kill them in 6 hours. To make that differentiation at that point is as much a skill as being a surgeon of the left nostril or whatever super specialization and there might be elsewhere. And I think that's critical. And I think the health system leaders could help bring about that value of primary care, because without that, this fundamental shift, which our WHO, the distinguished people in that panel discussion were talking about. We need primary care, but there is a way that can be done. It's been done in the UK, and it's worth looking at. I think my question was, even in Britain, where communication is part of undergraduate education and part of continuing professional development, all the rest of it, there is now a concern about how young people brought up in this digital era where all they do is look at their smartphones, and the levels of autism, inability to connect, even make eye contact with people, there is a significant rise of that kind of behavior and inability to communicate and connect. How is that going to affect our education, particularly in these caring services, where what you're looking for is those sort of words that were used, compassion, connection, etc. It's a question that you may or may not have an answer to today, but I think the responsible thing for system leaders will be to think about that going forward. Thank you.
Yeah, I think Dr. Priyanka, you have.
Yes, I think this it is almost similar to the question it has followed earlier. So this is something our all member states have been talking about, and that is how since 2022 Sri Lanka proposed the medical humanities also, which also like I explained, it brings around all social context to including the medical student or any health workers, how they will interpret their surrounding. So even if I develop my competence, for example, what is competence? It can be different. If I'm here, I would have to have different competence. Now, if I'm in a field, it would be different. Now, how do we define that and how can we ensure it? I think it's only exposure. So, for example, like here, how many of us did our formal education and we are continuing on a very traditional occupation we are in? For example, so started from clinical, now he's in public health. Yeah, for now. And yes, so every one of us, of course, that is one extra branch. But then while we are at medical school or while we are training our very formally, we look for exams. I think that is our goal while we are studying. But then there are other things it would come into play. We feel compassionate around someone when we know their background, when we know their surrounding, when we will be more humanistic when we go to the community and see what's happening. We prescribe one medicine, but the person is not able to buy it, or personally is not able to swallow it. Person is not able to differentiate between it. We don't think about it, but then when we follow the patient to their background, which I think it could come from this health humanities we have in
Thank you.
question, I think.
Thank you,
Yes.
Dr. Priyanka. I'm very sorry you have to close it here because of paucity of time. Just 30 seconds to summarize. This is a very important topic which could not have been discussed in this 90 minutes of this session and time that was allotted for this session today. I think the take-home messages are 3 or 4. One, this is an important public health dimension that need to be understood and kind of internalized by all of us. Second, there's a lot need to be answered in this front through community-based studies, policy briefs, and international collaborations. Third, human resources in health is an intersecting crossroad of all the health system building blocks that need to be kind of studied in a very unique manner because of the fact that it's dealing with human emotions. And finally, there is an action point for each one of us as public health researchers, students, academicians, and policymakers. We'll have to kind of go back and kind of discuss about it in different fora, and then probably through incremental manner. But someone actually pointed out we don't need relearning, we need reloading. So one of the speakers, in fact, actually spoke about it. Probably that's the way forward. But I think probably by the next year of conclave, we'll have more answers to this component. With this optimistic viewpoint, I would like to again thank all the panelists, the organizers, the audience, and the people outside of this, especially from the inside, the online people who are joining online. Thank you for your time and patience. Have a wonderful time ahead of you. Thank you so much.